Hello everyone. Today's topic is neuromuscular junction. My name is Shiraz Mumtaz. Okay. So objective for this neuromuscular junction is understanding what neuromuscular junction is and understanding of the pathophysiology of the myasthenia gravis, which is a neuromuscular junction disorder. What are the clinical features of the myasthenia gravis, and then how we diagnose the myasthenia gravis and how we treat the myasthenia gravis. Okay. First of all, you have to understand the structure of the neuromuscular junction. It has the axon terminal, the motor end plate, and then the synaptic cleft right here. Okay, so axon terminal right here, and then the motor end plate, and there is a space between this is called a synaptic cleft. Okay. So, neurotransmitter, which is a chemical that released into the synaptic cleft, okay, and then this acetylcholine, which is the neurotransmitter chemical, that helps in the opening of the sodium gated channels. Sodium then enter and then depolarize the cell, the motor end plate, and that is how the action potential is generated. Okay, so this is going to be graph like this. Okay, all right. The axon terminal contain the neurotransmitter vesicles, acetylcholine. Okay, acetylcholine is a chemical that change the permeability of the motor end plate, which causing the sodium influx. Okay, the in this in the synaptic cleft, we have the enzyme called the acetylcholine esterase that actually breaks up the acetylcholine, and then the choline goes back to the neuromuscular junction, which is the axon terminal, and then mix up with the acetyl-CoA, become the acetylcholine, and then waiting for the next stimulus come in, and then release again. Okay, all right. So this is a how does it look like? Okay, so right here we have all these structures which are gonna come in next. Okay, this is the enzyme called the acetylcholinesterase. This is the sodium, the acetylcholine gated channels. Okay, so the second event, what happened at the neuromuscular junction, as soon as the stimulus of the acetylcholine is released in the arrival of the action potential at the axon terminal, the action potential travel along the length of the axon. Okay, so right here in the beginning, we have the axon is going to go from the length of the axon, and then it is going to action potential reach right here. Before that, there is the entrance of the calcium in the perisynaptic terminal. Calcium is going to enter and then activate those neurotransmitter vesicles, and then helps in the release of the those chemicals, which is the acetylcholine. Okay. So right here, it is the what do they call this third event, that when the axon potential reaches the neuron axon terminal, the permeability changes, and then this triggers actually the exocytosis of the acetylcholine into the synaptic cleft. Okay, so right here, as you can see, this is the acetylcholine is coming out into the synaptic cleft. Okay, this is the third event. The fourth event that we have, the acetylcholine molecule diffuse across the synaptic cleft and bind to the acetylcholine gated receptor right here. These are the acetylcholine gated channels, and this is the acetylcholine that attach with the acetylcholine gated channels, and then that is actually helping the sodium to go in. Since there is a higher number of the sodiums available extracellular, then it is going to be sodium is going to rush in and cause the depolarization on changes in the membrane and causes the depolarization. Okay, all right. So I think I discussed this thing earlier. Okay, in the picture. Let's go to the fifth event. Okay, so the sudden inrush influx of the sodium ion results in the generation of the action potential in the motor end plate. The acetylcholine diffuses away from the synapse and are broken down in the by the acetylcholine esterase into the acetic acid and choline. And as I said earlier, that choline is going to go back to the pre uh, synaptic neuron, okay, and then it goes back to and mix up with the acetyl-CoA and then become the acetylcholine, okay. So this removal actually of the acetylcholine receptor membrane, okay, from the acetylcholine receptor membrane that closes the channel, okay. So right here, as you can see, whenever you see this is the acetylcholine esterase is diffusing it, so it is in the end is closing the acetylcholine gated channels. Okay, so For the myasthenia gravis, we have to understand, that is the neuromuscular junction. In this sense, we have the auto antibodies that is actually killing the or attacking the acetylcholine gated channels. Okay. So they have, our body produce the auto antibodies against the acetylcholine receptors. The antibodies targets and decrease the numbers and the function of the acetylcholine gated channels and disorganize their disposition of the acetylcholine receptors. The acetylcholine receptors antibody is directly dependent on the T cells with their CD4, the CD4 helper T cells, that produces the B cell to produce the auto antibodies against the acetylcholine receptors. Okay. Clinical features, okay, they are fluctuating, during the daytime, okay, which means there is less intense during the morning and much worse as the day progresses, especially in the nighttime. Okay. So at nighttime, it gets so bad, it's going to go so severe that, people are so fatigued and sluggish, and they're not able to perform the normal physiological function. Okay. An attack on the antibodies to the neuromuscular junction to the acetylcholine gated channels decrease the number of the acetylcholine receptors. Okay. Because the acetylcholine gated channels are decreased, the end plate become powerless because it does not have those channels. For example, if those channels are destroyed, there is no acetylcholine is going to do anything with it. Okay, so no gates, no transmitters can do anything. Okay, all right. So the amplitude of the motor end plate are not satisfactory. So amplitude, it is not going to be go all the way up. Maybe go a little bit up and then goes die down quickly. Okay, and repeated stimulation causes the fatigue and weakness in the muscle. The myasthenia gravis is clinically distinguished by the fatigue and a fluctuating and then fatigable weakness of the striated muscle. Usually, striated muscles are involved in it. Okay. Any striated muscles can involve in the myasthenia gravis, but more so the extraocular muscle, facial or pharyngeal. Extraocular muscles are to movement of the eye, so we are not able to move our eyes later on, including the closing our eyes. I mean, we are not able to open our eyes completely or close our eyes completely. Facial muscles, it is going to be no facial expression in the end of the day. It's kind of a Parkinson's of the nighttime, because you can say. Parkinson, we're gonna be different kind of pathogenesis, which we're gonna do some other time. Oropharyngeal, that helps in the swallowing, so that is going to be affected. Okay. Patient shows the fluctuating symptoms. Sometimes they feel all normal, okay, and sometimes they are all paralyzed. It doesn't is not related to only the myasthenia gravis. It can be related to any autoimmune disease, especially the myasthenia gravis. Sometimes they feel good, sometimes they don't. Okay, actually, I have a friend is affected by the myasthenia gravis. Okay, and she was once hospitalized for 1.5 months, couldn't pass her urine or move her eyes. But then now she is doing good amazingly and practicing in the New Hampshire. Okay. All right. So the test that we have, we have the Simpsons test, okay, which is, as you can see, the asymmetric palpebral ptosis. So you can see right here, this is up more up. The ptosis is the droopy eye in one side, which is the asymmetrical. Second thing, there we're gonna have them eye to look up for the 2 minutes, activating those muscles, the skeletal muscles that helps in opening of the eye. And then later on, you're gonna see those too much of the acetylcholine are used, then they're not able to open completely. Okay, so they're not able to close as well, which is also the voluntary muscle. They're not able to open or close as well. Both things are the voluntary effect. Okay. How you diagnose it? They're the electrophysiological tests. So we are going to stimulate, multiple stimulating the certain muscles, and actually that stimulation causes a delayed depolarization or no depolarization at the motor end plate. So maybe we send it it's gonna get that delay and then going up those what is it called? The action potential, or there is no action potential is going to be generated. It's gonna die down. Okay. So right here we have certain different muscle that has been used, which is adductor digitominis, tibialis anterior, upper trapezius, deltoid, okay, orbis oculi, and nasalis, okay. And as we said earlier, aim is to repetitive stimulate those nerves, okay, that stimulate the muscle, okay, and then in the end, the myasthenia gravis, which is causing the delayed or decreasing the transmission or delayed in the depolarization, okay. Serological test, we can have another test which is using the concentration of the acetylcholine receptor binding antibodies. Normal, even if it is normal, you cannot exclude it. Okay, so what are we going to use? So 80 to 85% they have these anti-acetylcholine receptor antibodies, but in the 80-85%. But for the other one, you can say only 55% purely with the what we call the ocular symptoms. Okay, the other test we can use is the acetylcholine receptor antibodies predominantly to the Ig, G1 immunoglobulin G1, and then G3 subclasses. We're supposed to have another the acetylcholine receptor antibodies and the muscle specific kinase antibodies. That is actually should be positive and should be positive. That result in is sufficient for the diagnosis for the myasthenia gravis. Okay. How we can treat it? We treat the symptoms only. We're not treating the disease, the symptoms only. With the pyridostigmine, pyridostigmine is a drug that inhibit the acetylcholine esterase enzyme. So the enzyme that is actually dissociating the acetylcholine, then if we decrease that enzyme, we are going to have much more availability of the acetylcholine and the synaptic cleft, and then more of the acetylcholine, maybe less of the receptors are needed for a certain amount of period. There is not going to be 100% treatment of it. It is just like a palliative treatment. Palliative treatment, which means we are just actually treatment the the severity of the disease, not actually treating the disease. Okay. Um, it compensates for the lower number of the functioning of the acetylcholine, talking about the pyridostigmine. Lower number of the acetylcholine gated channels are there, but more availability of the acetylcholine within the synaptic cleft causes decrease of the fatigability in person. Okay. Another treatment that we can use is steroid and immunosuppressive. So autoantibodies that affecting our immune system, we can decrease its effect by the prednisone and then other immunosuppressor suppressive drug like the azathioprine. Okay. The azathioprine and prednisone can use together, but the azathioprine can also be used in the patient to reduce the use of the prednisone, because corticosteroid has its own side effects as well, okay, which is not good, okay, in many ways. So to reduce the use of the corticosteroid, you can use the azathioprine to get the less use of the prednisone to get the maximal effect of the drug, okay. Again, we also should be doing the thymectomy, which is the removal of the thymoma in majority of the patient. Okay. Another treatment of the myasthenic crisis. Okay, at the time of the myasthenic crisis, we use the human immunoglobulin, which is IVIG, which is the immunoglobulin. Okay, and the also the plasma exchange, which is the plex treatment for the short term, and steroid and also other immunosuppressive drug are used, which is the prednisone and the azathioprine. Thank you very much.